Good evening. Welcome to the second night of the 2012 Honors Colloquium, Healthcare Policy, Healthcare Change, I should say, Health Politics and Money. Thank you for braving what they're saying might be bad weather. We're thrilled you're here, and I know you won't be disappointed. Just to do a few housekeeping details, the restrooms, there are 2 unisex bathrooms out in the lobby, and then downstairs, the doors that you would take if you're going upstairs, to your left would be the men's room, and to the right would be the ladies' room. And exits, there are 3 exits in the back, 2 in the front on the side, and 2 in the back on the side here. Okay. So at this point, I'm very pleased to introduce the interim dean of the College of Nursing, Dr. Mary Sullivan, who will be introducing our speaker tonight, Dr. Mary Wakefield. Thank you.
Thanks, Mary. I am thrilled to introduce Dr. Wakefield, who is the administrator of the Health Resources and Service Administration, called HRSA, an agency of the U.S. Department of Health and Human Services. Dr. Wakefield leads HRSA's efforts to fill in healthcare gaps for people who live outside the economic and medical mainstream. The agency uses its $8.2 billion annual budget to expand access to quality health care in partnership with healthcare providers and health profession training programs. Dr. Wakefield brings to HRSA a rare mix of high-level experiences in 3 worlds. She has worked as a nurse in both urban and rural healthcare settings. She was chief of staff in the 1990s to 2 senators from North Dakota, Kent Conrad and Quentin Burdick, and she has been a healthcare scholar and university administrator. She joined HRSA in 2009 from the University of North Dakota, where she was Associate Dean for Rural Health at the School of Medicine and Health Sciences. Dr. Wakefield's scholarly credentials also are evident in her election to the Institute of Medicine and selection as a Fellow of the American Academy of Nursing. Most notably, she served on the IOM committee that produced the landmark report To Err is Human and Crossing the Quality Chasm. Dr. Wakefield is a native of Devil's Lake, North Dakota. She has a Bachelor of Science degree from nursing from the University of Mary in Bismarck, master's and doctoral degrees in nursing from the University of Texas, Austin. She speaks tonight with the title, The Affordable Care Act and the Future of U.S. Healthcare. Please join me in welcoming Dr. Wakefield.
Thank you very much. It's just a delight to be with you this evening. And I'd ask, for the folks who are listening from right here in this room, how many of you have been through my hometown, Devil's Lake, North Dakota? But, 1. Oh, shocking, 2. Okay, I was afraid I was going to come to Rhode Island for the first time, this part of Rhode Island, and no one would know where I was from. But there you have it, 2 people in the audience. It's a special delight to be here, in part because while I've been to the airport in Providence before, I've never been outside, really, of that town. So I've had the opportunity to do a little bit of driving in what is an absolutely beautiful state. What a gorgeous setting. What a gorgeous setting for this university as well. I wanted to just ask, and this will be probably the last question, or one of the last questions I ask, how many nursing students or nurses do we have in the audience? Hands up. Okay, great. Special shout out to each of you, because I am a nurse, as was indicated by Dr. Sullivan, and I'm, of course, very proud of my profession, as we all are, whatever profession we pursue. So for those of you that might be nursing students, welcome to the ranks. I don't think you'll ever look back and wonder why you pursued this particular degree. I certainly have not. Before I begin and really talk about the Affordable Care Act and its impact both on healthcare delivery systems, but also talking about its impact on health, on the health of the nation. That's at least as important, and I would say even more important than thinking about the Affordable Care Act and its impact on healthcare delivery. Because at the end of the day, it's all about what we do to influence the health status of Americans across the United States, in rural and urban communities everywhere. Before I get into that conversation, though, about the Affordable Care Act, I want to talk with you a little bit about the agency that I operate. It is, as was mentioned, an operating division of HHS, the U.S. Department of Health and Human Services. So my boss is U.S. Secretary of Health and Human Services, Kathleen Sebelius. And my operating division is a little bit less well known than some of the other operating divisions. So, for example, some of you might be very familiar with NIH. You at least would have heard of it. FDA, Food and Drug Administration, maybe. Centers for Disease Control and Prevention. Well, those are some of the other operating divisions. Indian Health Services, those are sort of the sister agencies, if you will, to the Health Resources and Services Administration. Our agency isn't quite as well known, perhaps, as some of those. I say it's like the old Avis car commercial. Some of you are old enough to remember it. It's, we're not first, but we try harder, or something like that. So we're not as well known as the others, but we try harder at HRSA. HRSA, though, is slightly larger than a number of the other operating divisions. So I think it's worth your knowing something about what we do on behalf of the health and health care of the American public. The Health Resources and Services Administration, and I want to talk for just a minute about it to give you a little bit more of a sense of the agency, because I'm going to end up talking about what we're doing in this agency in implementing some of the provisions of the Affordable Care Act. And my guess is that some of the provisions I'll be talking about you may never have even heard of. And so that's why tonight might be an important conversation, an important time, to tell you a little bit about some of the things that you've not heard about. So the Health Resources and Services Administration is this big. This big is, it's about an $8.2 billion agency. So not in the millions, but in the billions of dollars. That's how big this part of the agency is. It has a complement of about 80 different programs with that focus that was mentioned in the introduction on ensuring access to high-quality healthcare services for underserved populations. That's really the mission. Most of our programs, most of those 80 programs are designed to help vulnerable, underserved populations. Well, what would make a population underserved? What would make a population vulnerable? It might be their health status. So, for example, we have the Ryan White HIV/AIDS program. That's a vulnerable population. We have certainly the population that we provide services for, or individuals who are donating organs. We oversee the organ donation and transplant system in the country. So that's a vulnerable population, obviously. We also have programs that are designed to meet the needs of economically vulnerable populations, people who are low income, who are poor, who are uninsured, and who are geographically vulnerable. So who reside in parts of the country that might be very rural, not unlike North Dakota, or even frontier. So that when I say vulnerable populations or medically underserved, those are the populations that most, not all, but most of our programs address. The 80 programs that we support have probably 4 or 5 that I think are worth highlighting specifically. And so let me just briefly mention them to you. And as I mentioned, some of those programs have been impacted directly by the Affordable Care Act. So a little bit later, I'll come back to them and tell you how they've been impacted. We are responsible for, so just to give you a few examples of some of those 80 programs, at HRSA, we're responsible for 1,100 community health centers across the United States. So those community health centers receive funding from taxpayer dollars that flow through the federal government and then go back into local communities to provide primary care, preventive health services to anyone who walks through the door. So they might have insurance, and they might not. They might be on Medicaid, they might not. They might be a veteran or somebody who's homeless. Might be a school teacher with health insurance. The point is the community health centers are responsible for delivering primary and preventive care, and they serve anyone regardless of their ability to pay. If you can pay something, then you do. It might just be $10 when you walk in the door, or $5. But if you can't pay anything, then you are still obliged to be seen. That's our contract, if you will, with community health centers. I mentioned to you that we have 1,100 community health centers across the country. This is an important program because it was resourced up markedly through the Affordable Care Act, something you probably don't know about, but as I mentioned, I'll talk more about later. We've expanded it a lot, though, with the enactment of the Affordable Care Act. So while we have 1,100 community health center sites across the nation, health centers across the nation, we actually have 8,500 sites. Think about that footprint across the United States. 8,500 locations where you can go to get health care services. Do you know some of them are mobile vans, and they might be parked in a church parking lot? That's what some of those sites are. Some of those community health center sites are 3- or 4-story bricks and mortar, state-of-the-art clinics, and all things in between. And do you know how, rhetorical question, do you know how many patients are seen right now in those community health centers across the United States? 20 million people get their care. And those numbers have increased in the last few years. With the expansion through the Affordable Care Act, infusion of resources in the Community Health Centers program, that infrastructure, that safety net infrastructure, has seen an additional 3 million people in just the last few years. So and we expect those numbers to continue to increase over time. That's part of the primary care prevention focus of the Affordable Care Act. As I mentioned, not always talked about. A couple of other programs. Oh, I should just mention, too, that we, of course, have community health centers. For those of you who are actually from Rhode Island originally, you might be interested to know that we have community health centers, of course, right here in this state that receive some of that funding I was just talking about. We've got them in Wakefield. It's a town I'd like to visit. We have them in North Kingston. We have health centers in Providence. In fact, in your state, we have 48 community health centers in this state. You might not have known it, but there they are, and in those particular locations. Other programs that we operate through the Health Resources and Services Administration, just mention a few others. I sort of mentioned to you the Ryan White HIV/AIDS program. That is a program that supports 900 clinics, 900 grantees across the United States that deliver healthcare services to individuals with HIV and AIDS. They provide top quality, high quality healthcare services. And how many people do they serve? They serve about half of all the people in the United States that have been diagnosed that have HIV and AIDS. So we serve about 500,000 people across those 900 sites. HRSA also supports the Maternal Child Health Block Grant Program. That puts resources into Rhode Island, puts resources into places all across the United States, every state. And what's the footprint of that program? So again, this little known part of the federal government, HRSA. But what the story I'm telling you is, look at the footprint. So not so well known, but you start to see really in a very palpable way how what we're doing in Washington and the programs we're implementing directly influence the health care down the street, down the highway from where we are right now. So on the Maternal Child Health Block Grants that go out to states, through those resources, we actually touch the lives of 6 out of every 10 women that give birth in this country and their infants through screenings, et cetera, that are supported through the resources that flow to states. We also, at HRSA, are responsible for health professions training. I'll say a word more about that in a little bit, and for scholarship and loan repayment programs. One of our programs in particular was also impacted by the Affordable Care Act, the National Health Service Corps program. That's a scholarship and loan repayment program for oral hygienists, if they were pursuing that career, for dentists, for behavioral mental health care providers, for physicians, primary care physicians, that is, and for primary care nurse practitioners, primary care PAs, and so on. So the National Service Corps is a program that places those primary care providers in underserved areas in exchange for paying for some of their schooling, by either paying off their loans or giving them a scholarship to go to school. We also have the Office of Rural Health Policy for the entire HHS department. That's located in HRSA, and it's really responsible for strengthening the healthcare, the rural healthcare infrastructure in rural communities across the U.S. We have an Office of Rural Health in your state. So it's just another way that we touch your state. Then in general, a magnitude of other programs, including poison control centers. So if somebody's ever had to make a phone call or has had a friend who's had to call a poison control center, we help to support those. The National Vaccine Injury Compensation Program, and the Federal Organ Procurement and Transplant Donation Systems, as I mentioned. And speaking of organ donation, and before I sort of start now to shift into a little closer to home, a comment about the University of Rhode Island, and then into the Affordable Care Act. I always sort of like to make a pitch about organ donation. We work with college campuses across the country. We work with all sorts of different organizations to try and increase the rate of donation in the country. This year, there's hardly a person in this room that would meet this criterion. But this year, we kicked off a new program called 50 Plus. And that's to really target people who are age 50. That might be some of your grandparents, for those of you who are sitting in the room. To really target people who are 50 or older and to let them know that they, more often than not, are eligible donors. A lot of times when people hit their 70s or 80s, even 90, they think, whoops, too old to donate. And do you know what? Sometimes you can have a much healthier 75-year-old than maybe some of you sitting in this room right now, at least hypothetically speaking. So the point is, we've got a big gap between the need, that is more than 100,000 people waiting in the United States for an organ, and we've got 18 people that die every single day because an organ is not available to them. So it's serious. I've got donor on my driver's license, and I've had it there for probably decades now. And so we'd ask all of you to think about getting involved too. Never too old, never too young to think about that program. Well, to deliver our services through HRSA, we do our work through about 3,000 partners. Local health departments, state health departments, hospitals, clinics, universities, just like the University of Rhode Island. That's how our agency does its work. We're very much a bridge between federal government and putting resources into local communities to better meet the healthcare needs of those individuals and families and communities. One of our important partners is, of course, this university, the University of Rhode Island. Really a terrific university that has made a serious commitment to offering affordable and very high-quality education. So congratulations to you and to all of the students that are enrolled here. We have been funding this university for quite a while. We have a number of ongoing grants that come right into the university, including, for example, more than $400,000 that goes just specifically to geriatric education, to a geriatric education center, just to give you an example. You can imagine that that's a pretty important investment because in Rhode Island and across the United States, as you well know, the demographics are changing. And so people here in your state, people age 65 and older, make up about 15% of the state's population. We're focusing like a laser on making sure that we've got the infrastructure, including healthcare workforce, to meet the needs of our aging population here in this part of the nation, elsewhere as well. We also have about $250,000 in funding into advanced nursing education at the University of Rhode Island. We also put money into student loans for the School of Pharmacy students, School of Loans into the nursing school, and probably have some other funds coming into the university that I'm not even aware of. We, of course, have other resources that go into many other universities and healthcare facilities in the state of Rhode Island. Well, that's sort of a background on HRSA, Health Resources and Services Administration, anticipating that maybe you didn't know a whole lot about that. But let me take your attention now right to the Affordable Care Act. The reason why I really did want to start out by telling you about HRSA is because, as I indicated, a lot of the programs in the Health Resources and Services Administration have been impacted, markedly strengthened by provisions of the Affordable Care Act. And in fact, the Health Resources and Services Administration, another little known fact, of all of the divisions of HHS, there's only one division, one operating division, that had more of the provisions of the Affordable Care Act for which they became responsible. Only one that has more responsibility in terms of numbers of provisions than HRSA, and that's CMS, the Centers for Medicare and Medicaid Services, CMS. So they've got the lion's share of responsibility. HRSA has the second largest set of responsibilities in terms of provisions. We're responsible for implementing about 63 provisions of the law, and we co-lead about another 15. So we've got a pretty significant role. And as a nurse and as the administrator of the Health Resources and Services Administration, I can tell you that since the day the bill was signed into law by President Obama, we have been working fast and furiously to implement all of the provisions for which we have responsibility. And so with that, I'll share from my vantage point a little bit about what it is we're doing. But let's step back for just a second and think for a minute about why that conversation occurred initially about the reasons that this law was needed. That is, why such interest in reforming health care just a few years ago. Let's look back for just a minute, and then we'll look forward to what we're doing. The answers back a few years ago were really quite compelling, and that is that we needed to look quickly at reforming health care because health care was rapidly exceeding or moving away from the financial reach of individuals and families and businesses in the United States. It was becoming rapidly out of the financial reach of large swaths of the American public. And healthcare reform was also important because we were certainly aware of variation in care quality, fragmented care. So there were opportunities and real need to improve care quality so that it would be consistent in its delivery, regardless of where you receive that care. Small town, Devil's Lake, North Dakota, or Providence, Rhode Island. So there were clearly gaps in the care quality. There was a mention of the Institute of Medicine reports that some of you might be familiar with, and I sat on the committee that produced those, To Err is Human and Crossing the Quality Chasm. They laid out in pretty clear narrative the significant gaps we have, and not just gaps in quality, but compromises to patient safety. People actually being harmed when they were seeking to be helped through medical errors. So challenges with care quality in some parts of the country, sometimes even within the same healthcare facility. High quality care on one floor, less so on the other. So you had this almost a paradox. Highest quality of care that you could find in the world in some respects, and then in other respects, that didn't hold true at all. So those were problems and decreasing access to care. All of those wrapped together had us on a very problematic trajectory. We also had a health insurance market that worked quite well for health insurance, for the companies themselves, but didn't work so well for a lot of families across the United States. So, for example, insurers could pick and choose who they would provide health insurance coverage to. Their choice. Their choice. They would often avoid, no surprise, covering people that would have pre-existing conditions through no fault of their own. This might be a child born with a congenital heart defect. It might be somebody who develops asthma when they're 14 years old. It might be somebody who develops diabetes when they're 21 years old, or a mental health illness. So insurance coverage historically was often avoided by companies for people that had healthcare conditions that required access to healthcare services. So in other words, the people who needed the most were standing on too frequently outside of being able to get access to health insurance coverage. And even then, premiums were skyrocketing. Health insurance premiums were going through the roof, even as health insurers, many of them were making record profits. So that made it hard and really sometimes impossible for families to afford health insurance coverage and for businesses to provide it as well. So you saw this consistent uptick in numbers of individuals across the country, year after year, who were uninsured for part of the year or uninsured consistently. Those numbers weren't holding steady. They weren't decreasing. They were going up. It was a trajectory that was just unsustainable. In fact, as you know, tens of millions of Americans were uninsured, and the numbers, as I said, continuing to trend upward. Millions more had coverage, but that coverage didn't cover preventive health care. It didn't cover health promotion activity and screenings, for example. It might cover, for example, only critically important treatments, high-cost treatments, if you will. And for those people who might switch their jobs or retire, those individuals could lose their health insurance coverage. So lack of choice in health insurance and lack of availability in health insurance was a big problem in health care that the Affordable Care Act was designed to address. The law, as I mentioned, also supports care quality. And there are a number of provisions that are designed to address quality of care. I'll just give you one in the Affordable Care Act, just one to make the point. There are many. The Partnership for Patients. That's one of the provisions that comes out of the Affordable Care Act, and it is a nationwide initiative that's underway. It's a public-private partnership that involves pharmacists, nurses, doctors, hospitals, clinics across the United States that are participating. It involves employers and health insurance plans and others. And the whole focus of the Partnership for Patient initiative is designed to improve the safety of health care so that people aren't harmed when they enter our healthcare delivery system, but that they're safe, that they receive high quality and safe care. The goal of the partnership, in other words, then, is to reduce preventable injuries, that historically occur far too frequently in the United States and is a major area of not just cost to an individual's health, sometimes resulting in patient deaths, so preventable error resulting in a patient's death, but also long-term harm, lost days from work and other instances, illnesses that people go home with, rehospitalizations, etc. So preventing preventable injuries is a big area of focus. And one of the ways that we come at it through the Affordable Care Act is through this Partnership for Patients that involves not just, as I said, the federal government, but partners across the United States. What's the goal? The goal is to reduce preventable injuries in hospitals across the country by 40% and to cut hospital readmissions by 20%. That alone would save more than 1.6 million patients from complications. Complications that, for example, force them to return to the hospital. And Rhode Island currently has 11 hospitals that are participating in this Affordable Care Act provision. They're participating in the partnership through the Hospital Association of Rhode Island, and they're focused on reducing nine specific hospital-acquired conditions. And those conditions include various types of infections and injuries and adverse effects. So that's the focus then of the Affordable Care Act is very much on ensuring access to healthcare services through insurance access. But it's also focused on care quality, as I mentioned, and also trying to drive healthcare costs down. Well, what the Affordable Care Act does, if that's the reason why we're here, in terms of the Affordable Care Act being considered and enacted into law, and some of what its purposes were designed to address, then what is it we're doing now in terms of implementation of various provisions? Well, let me mention some of those to you. And let me just start with our non-HRSA provisions, and then I'll go to the HRSA provisions. First, embedded within the Affordable Care Act, and by the way, some of what I'm talking to you about tonight is not what you hear about necessarily when you're talking to folks or you're listening to newscasts or radio talk shows, etc. But the provisions I'm talking about tonight are extremely important nevertheless. So one of the provisions you may not have heard talked about is a patient bill of rights. That protects patients from unfair insurance practices. Some of those practices I was talking about just a couple of minutes ago. So, for example, before the Affordable Care Act, and insurance companies could put a lifetime cap. They could put a ceiling on the amount of care that they would pay for you, regardless of whether or not you had a condition that had high costs associated with it. There could be limits on the amount of insurance and care that they would pay for. Today, as a result of the Affordable Care Act, more than 100 million Americans no longer face lifetime limits on health benefits. Also, prior to the Affordable Care Act, as I mentioned briefly, insurance companies could deny health insurance for people with pre-existing conditions. Do you know how many people there are in the United States with pre-existing conditions? Pretty close to 130 million people. Might not be anybody in this room, but you don't have to go real far outside the doors in this campus to probably find people that have pre-existing conditions. So people with pre-existing conditions who would try to buy health insurance coverage on their own were, as I said, often locked out of the insurance market. And sometimes these are individuals with potentially fatal conditions that required life-sustaining treatment. So this isn't about accessing health care that was optional. This was, for some people, a matter of life and death. But today, for example, the parents of more than 17 million children across the United States with pre-existing conditions like heart defects, for example, no longer have to live in fear that their children will be denied health insurance coverage. The Affordable Care Act has already banned health insurance companies from denying coverage to those children in the United States. So that's one of the things, just one of the things that the Affordable Care Act has done. And that's preventing insurance companies, prohibiting them from denying health insurance coverage for children with pre-existing conditions. In 2014, that provision extends to all ages. So already covered are children, and it extends to all ages, young or old, any discrimination against any age category of an individual of any age category with a pre-existing condition would be prevented. As of April 2012, so of April of this year, you have about 166 previously uninsured residents of Rhode Island that were locked out of the coverage system because of a pre-existing condition who now have access through the Affordable Care Act. So in real ways, right here, numbered in scores of people already impacted just by that first phase of that provision. The second way that the law makes sure that it helps people is by helping to address health care costs and making sure that health insurance premiums are spent wisely. So the Affordable Care Act created something, and boy, your eyes are going to glaze right over when I say this, but it's an important provision. Everything is important that I think that I'm talking about tonight, and sharing with you. But this one, your eyes will glaze over when I call it the 80-20 rule. So the Affordable Care Act has a new 80-20 rule that says to insurers, insurance company, you must now spend 80% of the insurance premium that you receive on health insurance coverage, on services, or on improving care. Or if you spend less than that, you need to refund the difference. You need to refund the difference. So 80% of premiums that are paid by employers, or if you've got your own health insurance coverage, has got to go to providing coverage for health care services to you, or to improve the care that you receive. Not to infrastructure of the, not beyond 20%, not to the infrastructure, for example, or salaries of CEOs, infrastructure of the company, and so on. So that rule is now helping to deliver rebates this summer. The rebates already started to go out for companies that were charging, or excuse me, that were violating that 80-20 rule. Rebates started to be paid back to individuals and to employers this summer. And what are those rebates worth? About $1.1 billion. That's how much money flows back to individuals who've been paying premiums when insurance companies were out of compliance with that rule. Additionally, the Affordable Care Act provides special relief for small businesses. In the past, this will certainly make sense, I'm sure, to anyone who comes from a small business. I do. My parents owned a small business and I worked in it. It's a little small crop dusting business, as a matter of fact. No, I wasn't a crop duster, but I was out there flagging fields. That's something that only the older folks in the audience would probably know about, because they don't put teenagers out in the field anymore waving a flag with a plane that's lined up on you and coming straight down that field to line up on you and release all sorts of herbicides and pesticides, and you're kind of hoping that you don't get to take quite a whiff of that, but depending on which direction the wind's blowing that day, who knows. But I digress. But my point was, I come from a small business family, so I've got a sense of what providing insurance coverage and purchasing insurance coverage for your family small business is all about. In the past, a small business employer paid about 18% more for the same health care coverage that a big chain store might pay just a few blocks away. That made it really hard for small businesses to compete. It made it hard for them to compete because they were paying more for insurance. That means that they'd have less money to pay for other things. And it made it hard for them to compete even on the insurance that they provided to their employees. If they weren't being able to provide the same level of services, but somebody else 3 blocks away was able to provide those services, that put them at a real disadvantage. So to address that inequity, the Affordable Care Act gives small businesses tax credits that have the potential to benefit an estimated 360,000 small businesses that provided health care coverage, for example, to about 2 million workers just last year in 2011. So there are also provisions not just for individuals and families, but for small businesses as well. The law, of course, also improves access to affordable care for young adults. And I wanted to especially mention this particular provision to you. This one I think you probably might know about it. Historically, for a lot of young adults, they would lose their health insurance coverage when they graduated from high school, when they graduated from college. The Affordable Care Act changed that for millions of young adults across the country up to the age of 26. So historically, as I said, if they if they were uninsured, they had a car accident, they came down with a pretty significant illness, and they were 25 years old, while they were uninsured, they or their families would be stuck with those often pretty significant bills. Or they might not, as a young adult, uninsured, be getting the health care services, preventive health care services, that they would want to be able to access. So under the law, most young adults, meaning those between the ages of 19 and up to age 26, who historically couldn't get coverage, can now get coverage through their parents' plans until the age of 26. And I would suspect that some of the people in this room may well be benefiting from that particular provision. That change has allowed more than 3 million young adults across the United States already to get health insurance coverage. So when you ask, what's happening with the Affordable Care Act, my guess is a lot of people may not even know that what they're able to get in terms of access to coverage, health screenings without copays, etc., a young parent who gave birth maybe 6 months ago to a child with congenital heart defects, etc., they may not even know that some of their coverage is now available because of the Affordable Care Act. So 3 million young adults under the age of 26 with that coverage now. How many right here in Rhode Island? About 9,000. About 9,000 young adults in Rhode Island have already benefited from that coverage. Well, let me shift off of insurance coverage and say a word or two about illness prevention and health promotion. One of the best kept, I'd call it a secret, but one of the things that I'd say is not so well known about the Affordable Care Act is that it focuses like a laser on keeping people healthy in very significant ways. We wouldn't begin to have the time to talk about the various provisions that are designed to ensure that people have access to primary health care services and that barriers are reduced to individuals staying healthy, taking advantage of immunizations, health screenings, and so on. But I can tell you, as somebody who practiced as a nurse for a number of years, practiced a good part of that time in intensive care units, I can tell you from personal experience that a lot of the patients that I saw and that I took care of on those evening shifts were patients who presented with illnesses that were preventable. But patients whose lives often hung by a thread because those illnesses weren't prevented. So something like high blood pressure that went unabated year after year, that resulted in a significant stroke, for example. So the Affordable Care Act, while not talked about in that context very often, has a number of provisions that really move upstream. Certainly takes care of people when they become ill, but really recalibrates the focus to focusing on keeping people healthy in the first place. So how does it do that? Well, it does that in a few different ways. First of all, it helps people stay healthy by providing access to healthcare screenings and preventive services that are now provided at no out-of-pocket cost. So no barrier in terms of being able to access many recommended preventive services. That means that people don't have to choose. They don't have to choose between getting a mammogram, a colonoscopy, a vaccination, an immunization, and paying for rent, for example, or paying for groceries, or paying for something that their child needs. That really, we think, helps people stay healthy and avoid costly hospitalizations. Last year, 54 million Americans with private health insurance took advantage of the law's expanded coverage for preventive health services, including 195,000 people right here in this state. So those provisions are already being rolled out. And going forward, while we've implemented a lot of provisions already, there are, of course, many more to come. The insurance exchanges that are being stood up in 2014, and a number of other provisions as well. Just for the sake of time, let me just make the focus real quickly, just say a word about Medicare and then straight into the Health Resources and Services Administration's responsibilities, a couple of specific provisions. Medicare, I've talked a lot about care coverage for kids and young adults, a little bit for families, and so on. But in addition to increasing access to insurance and healthcare services like preventive health services, and improving the availability and affordability of healthcare, there are a number of provisions that are specifically designed to address the needs that maybe some of your grandparents have in terms of access to healthcare services, in other words, for senior citizens. So, for example, the Affordable Care Act makes many of the key preventive services that are important, some of the examples I just gave a minute ago, available with no copay or deductible to people on Medicare. And in the first 7 months of this year alone, so from January through July, during that period of time, about 18 million Medicare beneficiaries took advantage of the law's coverage of preventive health services. That is, getting preventive health services with no out-of-pocket costs associated with it. In Rhode Island, you had more than 128,000 participants in the Medicare program that received preventive services with no out-of-pocket costs over the course of the last year. There are other provisions, too. We were on a trajectory to close what's referred to as the Doughnut Hole. Right now, the most recent add-in is a discount on covered brand name medications, a 50% discount on covered brand name medications. And thanks to the Affordable Care Act, there are now more than about 5 million seniors that fell into the Doughnut Hole, had coverage, and then lose it for a period of time, get coverage again at sort of the catastrophic end when their prescription drug costs ratchet up markedly. And as a result of the Affordable Care Act, as I said, more than about 5 million seniors in that Doughnut Hole have already saved an average of about $768. And by 2020, that Doughnut Hole is eliminated entirely. So this has direct impact then on Medicare beneficiaries and what their out-of-pocket costs are, both for preventive health services already and for prescription drug coverage. So important, critically important, especially in terms of polypharmacy and coverage of drugs for that part of the population. Seniors tend to have multiple chronic conditions and take a lot of drugs to treat those conditions. Well, let me take you now straight into the Health Resources and Services Administration, what we're doing there with some of the provisions of the Affordable Care Act. Beyond the benefits that I just outlined, there are a few key provisions that have markedly changed our work inside the agency that I lead and have changed many of HRSA's programs. I'll just tick off 2 or 3. One of them, the Community Health Centers program, mentioned it already. Second one, I'll mention the National Health Service Corps, a program that's designed to help support students in health professions careers. And then the third one, if I get to it, is the home visiting program. So I'll say just a word about the very significant investments that the Affordable Care Act has made in those programs to primarily expand access to primary care and to preventive health care services, very much in the communities that need it the most. So as I mentioned earlier, our Community Health Centers network delivers primary care and preventive care. It includes oral health, behavioral mental health services, substance abuse services in a lot of the community health centers. Not just the traditional health services you might get when you go into a traditional clinic, where you might go into an exam room and what you get there is that traditional set of medical services. Our community health centers are really cutting edge in this way. They're in many ways, actually, but they're certainly cutting edge in this way. They are comprehensive. They tend to be fairly comprehensive in the set of services that they provide. So when you walk through the door of many community health centers in the United States, you can get traditional medical care, let's say from a family nurse practitioner or from a family physician. You can also get oral health care from an dental hygienist and a dentist. You can also often get mental health services, treatment for substance abuse, for example, or other different chronic conditions, and you can get referrals to subspecialty care. That's part of that comprehensive set of services that are typically available through community health centers. So as I mentioned, our health centers, an essential part of the safety net, expanded markedly through the Affordable Care Act. As a matter of fact, the Affordable Care Act put over, between 2010 and 2015, through the end of 2014, about $11 billion into this safety net infrastructure to allow us to ramp up, again, that investment in keeping people healthy, investing in primary care and preventive health. So when I say that the Affordable Care Act, not much talked about, but incredibly having an incredible ability to impact health in the country, it's because of the expanded focus, not just caring for people after they become sick, but actually keeping them healthy in the first place. So that large investment was made in the Community Health Centers program, again, caring for people regardless of their ability, their insurance status or ability to pay. And health centers right here in Rhode Island provide services to probably about 120,000 patients are seen across just your health centers. And we expect with these investments, not just in Rhode Island, but across the United States, that availability, that access to primary care services is going to continue to expand as a result of the Affordable Care Act. As a matter of fact, Rhode Island received more than $24 million to enable your community health centers to see more patients, to deliver more primary care services along the lines of what I just described. The law also, for those who are nurses here, quick shout out for nurses, the law also provides lots of new opportunities through those community health centers for physicians, for pharmacists, for nurses, for social workers and others. But just to use nurses as an example, we now have about 16,000 nurses working in those community health centers across the United States. And that includes 4,300 advanced practice nurses. That is nurse midwives, nurse practitioners, and so on. And since those expansions began as a result of the Affordable Care Act, that is that pushing out of that primary care infrastructure, focusing on keeping people healthy. We've added 3,000 nursing positions in that infrastructure. And they'll be adding more as we continue to expand that part of the safety net even more substantially. Well, that's the safety net infrastructure in terms of places to go for healthcare services. What about the workforce that you see when you get there? Well, we've got lots of changes in a number of our workforce programs, but the one I wanted to mention specifically is the National Health Service Corps. This is a program that, as I said, repays loans or gives you scholarships to attend medical school, to attend a nurse practitioner program, and to become a dentist, and a range of other disciplines that can be pursued in exchange for service in an underserved rural or urban community. And financially, the National Service Corps is really a great deal. Pay attention to this. So, if you're in the National Health Service Corps, if you apply and you are admitted to the National Health Service Corps, you can have $60,000 of your loans paid back. Not $6,000, but $60,000 in exchange for 2 years of service in an underserved community. That means you're getting $60,000 back in loan repayment, but you're also getting your salary, of course, as a new practicing fill in the blank primary care provider. So pretty substantial funds, and people can continue and get additional loan repayment up to about $160,000. So think about the cost of medical school today or dental school. It's running right in that vicinity of $150,000, $160,000. And so this is a vehicle for people to attend school through scholarships, loan repayment, and then engage in service in exchange. We've got National Service Corps clinicians working in your state right now. We've got 35 of them working here. As a result of the Affordable Care Act, 21 of those 35 are here. As a result of the Affordable Care Act, think of the difference that one physician assistant, one social worker makes to a community. Every single one of them sees thousands of people over the course of a year. So coming through their doors. So clinicians make a huge difference, and that investment through the Affordable Care Act makes a big difference in terms of ensuring that we've got access to providers in our most rural and urban underserved areas. And as a matter of fact, we have more than doubled the number of National Health Service Corps clinicians across the United States. When I started, we had about 2,400 in the field. What do we have about right now? Largely as a result of the Affordable Care Act and before it, the Recovery Act, we've got about 8,600. Think about every one of those clinicians that are making a difference in an underserved community. If they weren't there, there might not be anybody there. Or there might only be one doctor there, for example, and now they might have two. Another area, the last one that I wanted to give you an example of, and by the way, the Affordable Care Act invested $1.5 billion in the National Health Service Corps, not just to supply more providers, but to help distribute them to the areas that need them the most in the United States. And you're benefiting, many of your communities are benefiting from that right now. The last program that I wanted to mention, the home visiting program, the home visiting program now is here in the state of Rhode Island, has resources coming to it from the Affordable Care Act, and is working in a number of communities, Newport, West Warwick, Central Falls, Providence, Pawtucket, and at least one more. And in Rhode Island, your home visiting program looks like this, just like the rest of the United States. The Affordable Care Act uses a set of evidence-based models to deliver health care services and support services to women with infants in high-risk communities. Notice that I said evidence-based. So this isn't, oh, we're going to apply for a grant and we're going to use any model and we're going to sort of try something out and hope that it works. This is saying, if you in your community or you in your state are willing to choose from one of 9 evidence-based models that have been shown to produce health outcomes, improved health outcomes for women and children, if you're willing to choose one of these as a state and invest those resources, the federal government, through the Affordable Care Act, is moving those resources into your state. And I just ticked off some of the communities where those resources are going right now. So the state of Rhode Island has selected 3 of those 9 evidence-based models. And they're proven models, as I said, that are known to improve health outcomes. Incredibly important because they focus not just on the health of, say, a young mother, but they also focus on social determinants of health, job skills, domestic violence, not just the health needs of the mother and the health needs of the infant, but also some of those other environmental characteristics that need attention as well, education, poor nutrition, and so on. It's not just about that medical needs, it's frequently about some of those other characteristics as well. And the expansion of these proven models through the Affordable Care Act puts resources right on the ground that are, as I said, proven to work. It's not talked about very much with the Affordable Care Act, but the example I just gave you isn't the only one of evidence-based provisions in the Affordable Care Act. There are a number of them, where basically the provision is structured in a way that says, you know what? We're using research. We're pivoting off of research. So for those of you that are in healthcare careers, you might be very familiar with evidence-based medicine or evidence-based healthcare. Well, let me say, there's also something called evidence-based policy. And so, and evidence-based programs that are being rolled out. And the example that I just gave you is just such an example. Well, the last area that I just mentioned is that within the Affordable Care Act, there are many provisions on even how we deploy our healthcare workforce. Not just producing more, not just helping to distribute them to high-need areas, but also investing in competencies of the next generation of healthcare providers. And one of the areas that we're focusing a lot of attention is on interprofessional team approaches to care, on care coordination. As a matter of fact, some of you might have read an article that appeared just within the last week that talked about, that estimated that about $750 billion, about 1/3 of U.S. healthcare costs, this is an Institute of Medicine report, were wasted in 2009. So a huge amount of money wasted, being used inefficiently for unnecessary services, excessive administrative costs, fraud, and other problems. Some of what the Institute of Medicine identified as a core catalyst for some of those wasted dollars going into healthcare, poor care coordination. So you see a lot of provisions in the Affordable Care Act that are focused, again like a laser, on team approaches to care, on coordinating care, and moving away from fragmented healthcare services that too often impacted even patients' health outcomes, in addition to being to driving up healthcare costs. So from our vantage point in the Health Resources and Services Administration, we've got a range of different health workforce programs, and a number of them we're driving now toward focus on embracing team approaches to care, both in the educational environments in universities like this one, but also in the clinical practice environments. We're focusing on physicians, we're focusing on nurses, we're focusing on pharmacists, other healthcare providers as well. And we're doing that by using the tools of the Affordable Care Act. Well, that gives you a rundown on a number of the provisions. I actually have more, but I'm going to stop because I've talked quite a bit, and I want to take a breath sometime. And actually just bring this part to a close. But wanted to at least give you that sense of a number of the major provisions. Those are just some of the ways, not all by a long shot, and not even all of the ways that the HRSA is involved in the Affordable Care Act. But what it ought to tell you pretty clearly is the areas that the Affordable Care Act focuses on in terms of reshaping health of the nation and reshaping health care. At the end of the day, it's very much about the health of the nation. And from my vantage point, where I sit at the helm of my agency, much of it is about investing resources to keep people healthy. Frankly, for probably really at this magnitude, certainly for the first time in my lifetime, have we ever seen an effort to move the needle and recalibrate so that our focus certainly includes care for individuals when they become ill, the very best care that we can give them, consistent high-quality care and access to it, but investing on the front end to keep people healthy, families healthy in the first place. So the Affordable Care Act in all those different ways explicitly supports high-quality care, accessible care, and tries to make it much more cost-effective for individuals that need health care. So with that, I'll stop right there, and I think we'll take questions with whatever time that we have left. water. Thank you. You're a good man. Thank you.
If you have questions for Dr. Wakefield, you can see the instructions on your screen. If you're using a computer or some device with a web browser, you can submit responses at pollev.com/2012 HOCO, or you can text Wakefield and your message, so the word Wakefield, and then the message, to the phone number 37607. Here's the first question. What are some of the challenges you expect to encounter in implementing the Patient Protection and Affordable Care Act?
It's a good question. So we've already, as I mentioned in my remarks, we've already been extremely busy implementing provisions already. And I gave you a lot of examples of people, by number, try to quantify the impact of some of the provisions that we've already been rolling out in terms of insurance coverage, expanding our community health center infrastructure, and so on. So some of the challenges, I'd say, were already past because we were moving very rapidly to stand up those provisions, many of them that had deadlines. So even within the law, there were deadlines for certain activities, for certain provisions to actually occur. That meant that for those of us that work in government, we were moving at a very, very rapid clip to get those provisions and programs implemented as quickly as possible. I think one of the challenges that I've seen, in addition to just not enough time in the day, because this is pretty much, for me at least, and for a lot of the people with whom I work, it's very much felt like a 24/7 set of activities, a lot of good work to get done, and a real commitment and a passion to get it done as quickly as possible, because we knew that people's lives were being impacted in favorable ways as soon as those provisions were implemented. Some of the examples I've already given you. But I'd say that one of the challenges that I think, from my vantage point, we encounter is that folks are not so familiar with some of the provisions that I even shared with you this evening. That's what I find when I'm out talking about the Affordable Care Act. Didn't know that there was a healthcare.gov website that I could go to, and that I could put in my zip code. First type in my state, and then put in my zip code. And then up would pop up all the health insurance policies that are available to me right now in my zip code, where I live, or where my aunt lives, or where my friend lives. Didn't know that that resource was even available. Data presented in a way that maybe for the first time you could even understand, because you could compare insurance policies in terms of cost and coverage, et cetera. So the challenge is how much people know or don't know about some of the provisions. Some folks may not even know that they've benefited from the provisions that have already unfolded and that they've directly benefited from. So I think one of our big challenges is explaining as we go along what's available, when it becomes available. And so that's why when we're out and about, when we have the opportunity to talk to audiences, I certainly try to do just that, to make sure that people know about the availability of the resources that are there right now, and those that will be coming online over the course of the next year or so. So big challenge, communication.
The next question is, preventive care is arguably neglected by healthcare providers because it's less profitable than conventional medicine. Do you think the solution is to find a way to more effectively monetize preventable care through government subsidies, or to educate individuals to improve their health through lifestyle changes such as diet or exercise?
Yeah, such a great question, too. So preventive care, sometimes I think folks may not know how important it is to have screenings, certain types of screenings. So some of it's just innate human behavior. I didn't realize that I should have had that fill in the blank done, and now maybe, say, colonoscopy, and maybe the colon cancer that I've developed could have been picked up a year ago. Had I known that I was at high risk for colon cancer because of family history, or that I was in an age group now where I should be getting these at certain intervals, colonoscopies on certain intervals, had I only known, I would have done that. Or I would have participated in preventive care, except there was a copay, and you know what? It was a copay that I couldn't afford. So I didn't get that preventive care, whatever that preventive care was. So I'd reframe the first part of that question a little bit to say that preventive care is neglected for different reasons. One, was it covered by insurance companies? Two, was there an if it wasn't covered, or if there was a high out-of-pocket copay, was that a deterrent? Or three, was it a lack of information about what preventive screenings you should be getting in your age category, for example, or what vaccinations you should be getting, for example? So I think those would be some of the factors that contribute to, historically, some of those factors we're trying to take off the table, but historically would have contributed to lack of access to preventive health services. Educating individuals, incredibly important. So, and I didn't even talk to you about the First Lady's Let's Move campaign, and then some of the provisions of the Affordable Care Act specifically that focus on healthy weight. We're operating one of them right out of the Health Resources and Services Administration. We're working in partnerships with teams across the country, focusing on healthy weight, which means diet, exercise, but using evidence-based models. Remember, I told you the Affordable Care Act tries to pivot off of evidence, and this is one of the areas where we're doing that too. Best practices where we don't have evidence, evidence where we do have it. And our healthy weight collaboratives that we've stood up in sites across the country aren't just being conducted by and through traditional healthcare providers. It's also with teachers, with parents, with parks and recreation departments, with other stakeholders, businesses that have an interest in healthy communities. So educating individuals to improve their health through lifestyle changes, absolutely high priority, and we're investing by working with communities across the country through some of the Affordable Care Act provisions. It's extremely important.
Before we get to the next question, just want to remind you that you can also fill out the cards, and they will come to the coordinators, and we'll enter it on the screen. So not only can you text and use the web, but you can also fill out the cards, and someone will pick it up, and we'll put it on the screen. Next question is, what is HRSA doing to focus on preconception health of young women?
Did that come from a nurse or a physician? Or a pediatrician, I should have said, or an OBGYN doc. One of the three. Okay, a pediatrician, right? Yeah, so this pediatrician could actually answer that question. I only know this because I had a quick opportunity to talk with him a little bit before, though we were not talking about this topic. As I mentioned earlier on, the Health Resources and Services Administration has responsibility for the Maternal Child Health Block Grant Program and for a number of different programs that directly impact the health of infants, children, pregnant women who want to become pregnant, etc. We are really reshifting our focus. What I was taught when I was a nurse in terms of the health of women and infants was very siloed. It's, okay, today you're pregnant. So now your health, the status of your health begins today. The day that you learn you're pregnant. That's when I've got to pay very close attention to the status of your health. And all the way through your pregnancy. You deliver that infant and done. Finished with that. It's just a segment of health, nothing to worry about, nothing that occurred before that would influence very much your health during your pregnancy, nothing that would occur afterwards that would tie into that pregnancy that you had. The preconception health is really not new for pediatricians today or new nurses today, but it would have been new for me, and that is to say a lot of what is healthy or not about the health of that pregnant woman and the infant that they bear is a result not just of the care they received while they were pregnant, but the care that maybe their mother received, the care that they received and their health condition and their nutrition when they were not 23 years old and pregnant, but 3 years old and 13 years old. And so with our resources, through a number of our programs, we're really focusing on preconception health of young women. Not just when they conceive, not just when they're pregnant, but actually what their health status is long before that. Because we're starting to see clearly characteristics of an individual's health that emerge long after, as a result of and linked to health status, social determinants of health that occurred much earlier in their lifespan. So that's really that new orientation. our programs, our complement of programs have taken on. We're embedding that in our Healthy Start program, which delivers healthcare services to underserved populations across the country through a number of our programs. But that's a pretty simplistic version of it. You could give a much better one than I just gave. But the point is, as I said, when I was studying, I would have been, for nursing, we would have been educated almost exclusively, not entirely, but almost exclusively on the health of that woman during their pregnancy. And now that's not the case at all. We're looking at how well that infant does based on maybe what that mother's health status was when she was 13 and links between. Was that sort of in the ballpark? Kind of.
Next question. How does the ACA address, at the other end of the spectrum, end-of-life care?
So that's a good question about palliative care, hospice care. The Health Resources and Services Administration doesn't provide services in those particular areas. Really, most of what we do is focus on primary care services. We invest certainly in geriatric education centers, and probably some of those centers would be looking very much at training in end-of-life healthcare services. But for at least for our part of the agency, I couldn't speak to that because that's not an area that we're focused on specifically. Sorry, we're a little bit more on the ambulatory care side of the equation.
How does that 80-20 rule get monitored? And is the provision saying that 80% of an individual's premium must be spent on the individual?
80% must be spent on healthcare services for the individual or on improving the quality of care that the individual receives, monitored by CMS, by the Centers for Medicare and Medicaid Services. And through their contractors. So,
what impact do you expect the Affordable Care Act to have on physical therapy practices?
That's a great question. Certainly issues around coverage of physical therapy, people who could access physical therapy services because they would now have affordable, accessible health insurance coverage. So you might expect that because of that, people who might have foregone access to needed physical therapy, now having coverage, would be able to take advantage of those services. And I'd say that would probably be one of the most important potential outcomes. That is actual coverage for people who historically might have needed the service, couldn't get it because insurance was out of reach.
And a follow-up, are physical therapists included in the National Health Service Corps?
They are not. Oh, no, they say. But they're not. But there are a couple of things that I'd say about that. We did, just last year, so for the physical therapists in the audience, which must be back there, last year, so we have lots of different disciplines that are interested in being able to participate in the National Health Service Corps. And you heard me describe the types of providers that can participate, that we define primary care in that sense pretty broadly, not just family medicine or not just family nurse practitioners, but also oral health services and behavioral mental health services. So we've got lots of different providers and disciplines that have asked whether or not they could be included. So we wouldn't begin to have the resources to be able to cover all healthcare providers, that's for sure. But what we did do last year is we asked the employers, the prospective employers, what do you need? What do you need? So for those health profession shortage areas, those clinics, those community health centers, rural health clinics, and so on, that are eligible to hire a National Health Service Corps clinician. And if that clinician would come and work for them, that clinician then would get that, would for example, be able to take advantage of loan repayment. We asked those employers, what do they need? So we got a list of about 7 or 8 of the highest need disciplines. One of them, pharmacists, the other, registered nurses, neither of which had been covered or are covered currently in the National Service Corps program. So what did we do? We took our resources that we put into states. We've got one part of the National Service Corps program that's called the State Loan Repayment Program. Rhode Island participates in this program. Right now, your state is putting $125,000 into the State Loan Repayment Program. We, federal government, are matching it. So state loan repayment requires a state match. States can choose to participate or not. If they choose, they can decide if they want to place and repay loans for pharmacists or registered nurses. So those are the two new categories that are now available through that loan repayment program. And it was as a result, not because of some sort of off-the-cuff decision that we made, but rather really querying the prospective employers to see what their needs were. So we just opened that up. The states don't have to expand those categories to include pharmacists, for example, but they can if they choose to. So those would be two new ones. So the point is, my point is to say, not there now, but we're constantly trying to understand what the greatest needs are in underserved communities and meet those needs, thus the recent change. And we'll continue that.
Why do you believe that most individuals, or some individuals, oppose the Affordable Health Care Act as a whole while supporting individual sections? And what can professionals in the medical field do to help inform their patients about the reality of the bill?
Well, the information about the law, I think, is extremely important because we want to make sure that everyone who's eligible for any of the provisions that I talked about already or will be eligible to participate, for example, in health insurance exchanges in 2014, know that they're eligible. We don't want anyone who could benefit from health care to not realize that health care is now available to them as a result of the Affordable Care Act. So for us, communication, information is extremely important, and it will become more so as those state health insurance exchanges are stood up beginning 2014. So communication is extremely important. Healthcare providers are critical. That website I mentioned earlier, healthcare.gov, I can't tell you how often I've been on it and how often I've sent people to it. Healthcare, all one word. That website is updated constantly. And as I mentioned, you've got state-based information there. It's not just generic information. It's talking about provisions that are available right within your community or in your state as provisions roll out that might be specific to your state, like where is a health center, community health center located, for example. So that kind of information is available, and that's where providers can probably help the most to make sure that their patients and their communities, not just their patients, but because healthcare providers tend to be leaders in their communities, that their communities are aware of the provisions of the Affordable Care Act. Why do I think that there's opposition? Well, I'd say you can look back to any major, almost any major laws that were implemented in the United States. I can't think of any of the major ones that I'd reflect on right now that didn't have a lot of diverse opinion expressed about them. Social Security, lots and lots of back and forth, very diverse opinions about whether or not Social Security, when it was first enacted, was the right thing to do. Medicare, back in 1964 and 1965, some health professions associations opposed Medicare when it was first enacted. They're not professions that oppose Medicare now. You can think about people who are age 67, 69, with that insurance coverage that in the early 1960s didn't exist. It was hotly contested in 1965. Hotly contested. So enactment of major laws, this is not unique to the Affordable Care Act. It certainly has been characteristic of laws that were enacted historically. I also think that there's a lot of misinformation and there's confusion about some of the provisions of the Act, of the Affordable Care Act, and that probably contributes to that, to certainly questions, and in some cases, if it's misinformation, opposition. And then everyone does have different opinions about different provisions. So that's sort of human nature, that we don't all agree on absolutely everything. So.
One last question. Thank you all for your questions. We received many to select from. Dr. Wakefield, what do you see as the next big step in healthcare change?
A lot of innovation. Unbelievable innovation. So for those of you that are thinking about healthcare, it's be ready for change. It's make sure those your seat backs and trays are in a locked and upright position because we are taking off. It is a time of lots of opportunity. We've got a toolbox that we've been given that allows us to move in new and different directions and that we have from how we've engaged health and healthcare historically. And we're seeing innovation emerging all across the country. We are supporting innovation through our Centers on Innovation in the Centers for Medicare and Medicaid Services. We've got phenomenal new innovative care models that are being tested right now, and they're grassroots. They're coming out of communities. This is not Washington, D.C. saying, here's what you need to do to model this. This, unless it's an evidence-based model and we know it works, then home visiting would be an example of that. But we're asking for a lot of innovation and models that are being constructed at local levels. Center for Medicare and Medicaid Services just funded maybe about 107 new initiatives across the United States that harness telehealth technology, harness telemedicine, field community healthcare providers, not just the traditional healthcare providers, but are putting people right out in the community, focusing intensely on illness prevention, health promotion. I think some of them, I'm not exactly sure, so I won't continue that sentence. But looking at reconfiguring the way we deliver health care. So what's happening? We're seeing in communities across the United States re-engineering of healthcare delivery. Some of that being supported, of course, a lot of it by the Affordable Care Act, a lot of it. But a lot of it emerging almost even separate and apart from what the Affordable Care Act has underway. So folks who are sitting around the table and saying, we see opportunity to improve the way we're doing our work, harnessing electronic health records, harnessing health information technology, working in teams, enhancing efficiency and effectiveness, tracking patient outcomes in a more consistent way, using research to inform our performance improvement. So lots and lots of innovation. And I'd say the next big step in healthcare, lots of change, and good change. So, does that suffice? Okay, because it's really hot up here, let me tell you. Thank you very much. Thank you. It's a pleasure. I'm going to grab that water, absolutely.
Thank you so much, Dr. Wakefield, for a very informative talk. I think I speak for everyone that we all feel much more informed to the various provisions of the Affordable Care Act. So thank you very much. Okay. Next week, we're going to be changing gears a little bit. Our speaker will be Captain Robert Tussato of the United States Public Health Service, and he's the director of the Division of Civilian Volunteer Medical Reserve Corps, and he'll be discussing how health, politics, and money affect participation in public health initiatives in disaster preparedness. I hope you can join us. Thank you very much.